Good morning. Welcome, everybody, to our December Grand Rounds. Dr. Paul Manner and Dr. Boris Kovalenko are going to talk to us about charges, costs, and bundled care, where we are and how we got there. And they have quite a few slides to go through, and I believe this is going to foster quite a bit of conversation when we're done, so we want to get started promptly. So thank you.
I'm one of the fourth-year residents here at the University of Washington Department of Orthopaedics and Sports Medicine. I'll be presenting with Dr. Manner on bundled care. I'd like to start by saying I have no disclosures. And I think that in the process of learning about all this, if I could summarize everything that I've learned into one slide, this would be it. This is an incredibly confusing topic, and every time you think that something makes sense, you read something else that makes it even more confusing. It's a very big picture, and there's a lot to talk about. So we'll go ahead and start with an intro, then we'll talk about some bundled payment models, we'll discuss quality, and then we'll hand it over to Dr. Manner. Congress introduced the Patient Protection and Affordable Care Act in 2010 to provide care to more people and to address rising healthcare costs. In 2015, these reached a total of $3.2 trillion, or nearly $10,000 per person. And a number of programs were introduced as a part of this act, including the CMS Innovation Center, which was designed to test alternative payment models. Up until now, we've been using fee-for-service as the traditional payment model in which third-party payers are billed for each visit, test, procedure, and treatment provided. They're billed during the initial visit, subsequent visits, as well as readmissions. Shortcomings of this model are that fee-for-service payment may fail to encourage cooperation, it may fail to control the volume or cost of services, and it doesn't do much to reward providers for quality of care. So under fee-for-service, everyone used to bill separately: the surgeon, anesthesiologists, rehab doctors, therapists, and there wasn't really much of an incentive to economize. Now we're transitioning towards a philosophy of considering quality over quantity and changing reimbursement from volume to value. Bundled care is a good example of value-based care, and it uses a comprehensive payment to cover all aspects of the patient's care during a predefined episode. One of the goals is to provide or incentivize providers to eliminate inefficient care. And again, as far as why should we be changing and restructuring our payment models, fee-for-service doesn't do much to encourage cooperation, control volume, control costs, and it doesn't really focus much on quality. And our intent is to decrease healthcare spending while improving or at least maintaining quality. We can do this by creating incentives to eliminate clinically ineffective or duplicative services. So here, while doing my literature review, I found a nice chart that summarizes commonly used abbreviations, and there's quite a bit. This is just highlighting the fact that when reading literature about bundled care, you're frequently referencing back to these tables to figure out what the acronyms mean, and it tends to be quite challenging. So in 2013, CMS enacted the Bundled Payments for Care Improvements Initiative. In this, Medicare pays the hospital a discounted amount based on the payment rates used in the original Medicare program. Providers share the risk of financial responsibility for postoperative events, and this allows providers to become shareholders who share in increased cost savings. This was trialed between 2013 to 16. It included 48 separate episodes, of which several of them were orthopedic, including lower extremity joint replacement. Postoperative expenses have been the largest and fastest growing portion of Medicare spending, and under this model, CMS is now saying rather than paying for it all, we'll give you a chunk of change, you guys can sort out the rest. So risks of getting involved with bundled care are that you have to worry about costly readmissions, admissions to postoperative care facilities, and potentially even owing CMS money at the end of the episode. So where can money be saved? If providers are to carry the burden of financial risk, then we need to identify areas of cost containment. These are either going to be during the acute admission or the post-discharge period. With bundled care, decreased spending is incentivized, and it can lead to additional repayments from CMS. So early results from the BPCI indicated that total Medicare episode payments declined without any sort of decrease in the quality of care, quality being defined as no increase in readmissions, mortality, or perioperative complications. And they found that a lot of these episode payments declined through a reduced intensity of post-acute care, so reductions in institutional care such as inpatient rehab, skilled nursing facilities, and increases in utilization of home health care. Interestingly, the total Medicare spending was actually higher during this period due to the reconciliation payments that were made for compliant programs. The CMS Innovation Center notes that even though the BPCI model is complete, the evaluation is still incomplete. They still have 7 more quarters of claims and assessment data to evaluate and determine what's exactly required to entice participants to engage in this program without totally offsetting those lower payments, because as I mentioned, the total Medicare spending was actually higher under this model. Some concerns about the bundle payment care improvement initiative are that it's costly to get involved in this. You need to develop the appropriate infrastructure, and not every hospital is well suited to do this. It may potentially restrict care for higher risk patients and lead to cherry picking. And as we perform more and more primary arthroplasties or other procedures on patients, what are we going to do when they come back and they have more costly revisions and other complications to deal with? Based on the success of the BPCI, CMS subsequently introduced the Comprehensive Care for Joint Replacement model. This was a mandatory initiative, and it was similar to but unique from the BPCI. This was designed to test a broader, different group of hospitals with the goal of providing CMS with information about testing bundled payments to hospitals that are mandated to participate in this rather than volunteering to participate. Hospitals are held financially responsible. There's target prices for the different Medicare severity diagnostic related groups, and the target episode prices are updated annually, initially based on regional and institutional data, and eventually based solely on regional experience. So at the end of the performance year, hospitals have the potential to either earn or lose money for the difference between the target price and the actual episode spending, but this is only if they achieve a certain level of quality. Quality was measured in the CJR model using 2 separate forms: the THA-TKA complications measure, which assesses a participant hospital's risk standardized complication rate in the 90-day period following total joint arthroplasty, and the hospital consumer assessment of healthcare providers and systems, which is a publicly reported survey of patients' experience of hospital care. Additionally, CGR allows for voluntary submission of patient-reported outcomes as well as risk variable data. This is incentivized and increases the hospital's composite quality score. The PROs that they accept are the Promise 10 or the VR12, the Veterans Rand 12, both of which are generic looks at health status, as well as the HOOS and COOS. And risk variables include demographics such as age, gender, ethnicity, BMI, ASA class, etc. So overall, when this was introduced, CMS predicted that this would save about $343 million. Obviously, time always tells the true story. Since this program has been initiated, they've decreased that figure by at least $100 million. Here's a map which shows the various regions of the United States that are participating in this model in the year 2016. And here's some hospitals in the Seattle, Tacoma, Bellevue area that are participating in CJR. So here's a nice chart that I found in a review article in the Journal of Arthroplasty that highlights the differences between BPCI and CJR, as they do seem similar, but they are unique on paper. The main differences are that CJR is mandatory. It's specific to total joint arthroplasty. The episodes are predefined at 90 days. This makes hospitals financially responsible. There's regionally influenced target prices, and there are discounts based on patient quality scores. Regarding the decision to make the model mandatory or voluntary, CMS argues that mandatory involvement eliminates selection bias, which is inherent in the BPCI model due to hospitals self-selecting themselves to participate. Based on the success of BPCI and CJR, CMS subsequently announced a new model, the SHIFT model, surgical hip and femur fracture treatment, which was another bundled care model designed to be targeted towards patients being cared for femur fractures. This was supposed to go from 2017 to 2021, but this was actually canceled before its initiation. Reasons were that CMS cited that the program wasn't fully fleshed out, it was being rolled out too quickly, and it may not have been beneficial to providers or to CMS, and they wanted to focus their efforts elsewhere. So we've now covered some examples of bundled care being tested by CMS. Again, we're doing this as part of a transition to a system that's emphasizing value over volume. In order to improve our value, we need to improve or maintain quality while decreasing costs. With these bundled programs, they put the burden on providers and hospitals to wring out inefficiencies in the current system in order to improve the value of healthcare which we provide. So has restructuring repayments done much to improve quality? There's an excellent review article in the Journal of Arthroplasty by Siddiqui et al., in which they looked at alternative payment models, BPCI as well as CGR, and they found that hospitals engaging in these models did have reduced costs, they did have improved quality, and mainly via reductions in length of stay, readmissions, and reduced use of post-acute care facilities. Similar findings were echoed in the study by Iorio et al. From NYU Langone. This is published in Journal of Arthroplasty in 2016, where they also found shorter length of stay, lower readmissions, and lower discharge rates to post-acute care facilities under the BPCI model. So it's also important to look at ways to improve our current processes. Adherence to evidence-based processes of care increase the likelihood of maximizing our health while minimizing adverse outcomes. And TJA, total joint arthroplasty, is a reproducible and reliable procedure with standardized postoperative courses. Clinical care pathways can help to streamline the pre- and postoperative processes to keep the ball rolling on course and everyone on a similar track. Tessier et al. Published an article in Journal of Arthroplasty where they did a cross-sectional study of patients treated under a BPCI episode, and they divided patients on whether or not a clinical care pathway was used. They found that the group with the defined post-acute clinical pathways showed consistent decreases in cost and utilization, with cost savings of over $3,000 per episode for total hip arthroplasty and nearly $2,500 for total knee arthroplasty. Walter et al. Published an article in Core looking at factors for successful pathway implementation, and they noted that preoperative education, standard orders, and a nurse practitioner to champion the pathway and ensure compliance were all critical to successful implementation of these pathways. Sutton et al. Looked at a National Surgical Quality Improvement Program data to consider early versus regular discharge, early being days 0 to 2 and regular being post-op day 3 to 4. And they found that patient comorbidities and perioperative variables such as longer procedure duration and post-op transfusion were independently associated with major complications, but early discharge was not. So they advocate early discharge in appropriately risk-stratified patients. McLaughlin et al. Used similar data to compare total knee arthroplasties discharged home versus to inpatient post-acute care, and they found that those discharged to post-acute care facilities had higher odds of complications as well as readmissions. They advocate for discharge home when feasible. So in order to keep track of our outcomes, we need to keep track of outcomes to demonstrate value to our patients as well as the healthcare system, and one of the benefits of the CGR model is that they encourage submission of healthcare outcomes, like I mentioned, the VR12 or PROMISE and HOOS and COOS. Total joint arthroplasty is an excellent example to use for the study of bundled care because it's a common diagnosis, the indications are clear-cut, and we have successful and valid treatment options. Given the high volume nature, there's a wealth of information that can be gained from these registries, and consistent use of PROs between and by providers can help us further elucidate areas for improvements and maintaining and improving our quality. Joints is a great case study for this because it's a hot commodity. There's a lot of procedures being done. It costs a lot of money to CMS, and so it was a good place for them to start testing these novel repayment models because of the high volume and high expense. So in conclusion, we're now shifting towards a system where we're focusing on value over volume. CMS has demonstrated efficacy of bundled payment programs with BPCI as well as with CJR. So it's encouraging us to work together. We need to start using more evidence-based clinical pathways to improve the efficiency of our care. In appropriately risk-stratified patients, we can decrease length of stay and we can discharge home when able. So next I'll be passing the mic over to Dr. Manner.
Perfect. Boris, thanks a lot. I mean, I just have to give a little shout out to Boris here because this is not an easy topic, and it is essentially like learning a foreign language. And how he did this while he's also being a resident and studying for the OID and all the rest of it, and looking for various fellowship programs. I'm not sure how you do it, but in any case, what I wanted to do is sort of kind of explain a little bit of how we got into this mess in the first place. And I titled this after Dantes Inferno. a lot of this looks like it makes no sense, and the initial response is, you know, well, I clearly don't understand this because somebody understands it, and after you read it for, you know, a few months, you realize that nobody really understands what's going on. And the reason it seems like it doesn't make any sense is because it doesn't make any sense. So my obligatory disclosure slide, none of these disclosures have anything to do with the subject of my talk, although obviously I get paid to operate, so that's a potential conflict of interest. So, you know, I realize that not everybody shares my passion for the economics of healthcare, but I will ask you to try and stay awake while we go through this. So, the history of health insurance really in this country goes back to the turn of the century when it started out with something called a sickness fund, which was something that had existed since at least the time of the Civil War. And essentially what happened is that employers or unions or fraternal organizations like the Elks or the Knights of Columbus would form a group, and each worker would kick in a small piece of their wages every week, maybe 1%, with the idea that if one of them got injured, the rest of them would band together and you know, pay up to perhaps 60% of the injured worker's wages. And so this was the beginning of Workmans Compensation, and it came about for a few reasons from the employer's viewpoint, because number one, the employer was liable for injury if they were found at fault. It was cheaper than fighting in court. It was more politically correct to show that at least give the appearance that they cared about their workers, and because it became the law. And in the years before World War I, several states made bold attempts to provide universal coverage. All of these were shot down, and as you can see from this statement from a Brooklyn doctor in just about 1914 or so, state insurance was un-American, unsafe, uneconomic, unscientific, unfair, unscrupulous, and so on and so forth. So you can see that even in the days before Twitter, political discourse in this country was not of the highest caliber, shall we say. So World War I comes along, and eventually the Depression hits. And the Depression hits hospitals hard. Donations drop by 2/3, and all of a sudden there are a lot of people out of work, they have no money. So Blue Cross starts as a hospital program at Baylor to keep the doors open. And essentially what they do is they go to the teachers and say, listen, if you kick in 50 cents a month, you will have 21 days of hospitalization covered. And this concept is very attractive to hospitals. However, there are some problems there because in order to be a real insurance company, you have to follow some laws. You have to pay taxes, you have to follow strict accounting rules, and most importantly, you have to have a reserve, meaning you have to be able to pay all of your claims. And the Blues said, well, we're a charitable organization. The insurance companies at the time said, no, you're not. You're an insurance company. And eventually, what happened is that the state legislatures were called on to resolve the dispute, and they resolved it in favor of the Blues. And what they said is that these service benefit plans were nonprofit and exempt from reserve requirements and from state premium taxes. Blue Shield started a few years later, and it's the same basic idea. The difference being is that Blue Cross covers hospitalization and Blue Shield covers doctor's fees. And the idea was that the plans would pay the patient a dollar amount for each covered event, and then the patient was responsible for paying the balance to the physician. Some other models came about. These were prepaid group practices, and essentially the idea here was that doctors would form a group, charge a fixed fee, and provide all care. And as you can see, it didn't go over terribly well. It started in Los Angeles. The founders were expelled from the medical society. In Oklahoma, the founders were expelled from the medical society. Kaiser started in California. He was charged with unprofessional conduct and was kicked out. And same thing happened in Washington State with Group Health, where the AMA and the local medical society engaged in reprisals. It actually went all the way to the Supreme Court, and eventually the Supreme Court told the AMA and the local medical group to knock it off and stop being so difficult. So commercial insurance really started around the time of World War II, and this is where things start getting complicated. And essentially there was a labor shortage because many of the working age men were off fighting wars, and there was a labor shortage. And this is, for example, is where women start coming into the labor force in larger numbers. But there was a problem. because there's a labor shortage, normally you would expect that the cost of labor would go up, wages would go up, but you couldn't do that because the federal government had price controls in place. So what they did is they offered benefits, and those benefits included insurance. And once the war ended, organized labor got into the picture and said, no way are you taking these benefits away. And in addition, in 1943, the IRS ruled that these employer-provided benefits were not subject to taxation. And this is a key reason why the U.S. health insurance market looks the way it does, because essentially the tax code effectively encourages employees and their employers to shift compensation away from taxable income, whatever you get in your paycheck, to non-taxable benefits such as health insurance. And this is a big deal because this accounts for about $250 billion every year of what you could consider lost income tax wages. And that's almost the amount that we spend on Medicare, so this is not a small amount. So World War II ends, we win, and Truman tries again for a national health insurance plan. The doctors and the hospitals say no. That being said, though, they are very much in favor of building more hospitals, so that happens as a result of a bill called Hill-Burton. And everybody realizes that taking care of old people, even poor ones, is lucrative, so various programs are developed to start that. Finally, in the 1960s, the federal government truly gets into the insurance business. Kennedy is assassinated, Johnson gets elected, and the Great Society programs are enacted. And Medicare and Medicaid get enacted in 1965, and this is easily, the best way to think of this is it's a kind of a three-layer cake, all right? So Part A covers hospitals, so the hospitals are happy because they're getting paid. Unions are happy because the money used to pay the hospitals comes out of Social Security and not out of payroll taxes, so they're happy because their members don't have to pay for this. Part B pays doctors, and so the doctors like this. The Republicans like it because it's funded out of general tax revenues as opposed to and premiums on seniors rather than making the doctors take a hit. And then finally, there's a SOP to poor people, which is an expansion of Kerr Mills, the low-income seniors, to more low-income groups. And for a while, everything goes as planned. The Blues dominate private insurance, and Medicare and Medicaid are fairly small programs that are used for the elderly and the poor, respectively. But ERISA, which stands for the Employment Retirement Income Security Act, in 1974 changes this. This was originally enacted in response to Studebaker going out of business and basically stranding all of their employees with what were essentially worthless pensions. And there was a small provision in there that said you could self-insure. Employers all of a sudden look at this and go, hey, it's a lot cheaper for us to develop our own insurance plan than to pay the Blues to do it. So all of a sudden, they become very interested in providing their own insurance. In addition, because these plans are no longer covered by state laws, large employers now become much less interested in damping down the possibility of state mandates, and so it's a lot easier to pass them. As a result, you have state mandates that start to crop up, things like podiatry is covered, chiropractic is covered, in vitro fertilization covered, psychiatry is covered, on and on and on, to the point where you have over 2,000 of these things across the country by the year 2011. So the 1980s saw a rapid increase in health insurance premiums, and this was driven by technology and by cost-based systems. So in 1983, Congress changes the way Medicare pays hospitals, and rather than paying on what's called usual, reasonable, and customary, which is essentially the doctor says it's going to cost this, and the insurance or the Medicare says, okay, here's your money. They say, no, we're going to do this based on allowable, on a DRG, which stands for disease-related group. And here, the hospital and the physician get paid a fixed amount based on the diagnosis of the admitted patient. So this changes things fairly significantly because it's no longer a blank check. The other thing that happens is the advent of HMOs, or health maintenance organizations. There are various systems or various ways to do this. A staff model like group health, a group model like Kaiser, where The Kaiser is the insurance, and Permanente is the medical group. It's a little bit of a distinction without a difference. But the basic idea here is that the HMO is an insurance company, which means that they truly bear claims or underwriting risk. And since they're responsible now for all the costs, they're very aggressive about controlling costs by restricting which providers can be seen. You have a small panel. Only a certain number of doctors can see you. And you use primary care doctors as gatekeepers. So instead of saying, hey, my knee hurts, I want to go see an orthopedic surgeon, you have to go see your primary care doctor who goes, you don't need to see an orthopedic surgeon. Or conversely, yes, you should go see an orthopedic surgeon. So there's some problems with this. Why didn't they work? Well, the answer is that the doctors don't like HMOs. Why don't they like them? Because free flow of wealthy patients is all of a sudden curtailed. Doctors don't like that. And they tend to band together. And they start to form very large groups, which essentially can control the local market so that the HMO now has to deal with them because otherwise there are no doctors involved. So example in Seattle is ProAlliance, which has over 100 care centers, about 250 physicians. Another example is down in Atlanta, a group called Resurgence, which has over 100 orthopedic surgeons in various offices in the Atlantic area. The other thing that happens is the patients hate HMOs. They don't like being told that they can't go see the orthopedic surgeon when they have knee pain. They don't like going to see their gatekeeper. And as a result, the HMO plan or the HMO system tends to go away. So new forms of managed care evolve, and these form the majority of current insurance plans. So essentially, the previous method of paying the usual, reasonable, and customary to any provider has gone away, and everybody's making deals and signing contracts. Essentially, what the PPO or the POS will do is go to the physician groups or to hospitals and say, we're going to pay you this much. Is that okay? You argue back and forth. Eventually, you come up with a number. The insurance company now goes to employers and says, after taking a small slice of the proceeds, says, okay, well, we can offer this network for this amount of money. And within a few years, conventional plans are basically gone. And you can see what's happened here, that conventional plans that paid the usual and customary went from comprising 2/3 or 3/4 of the market down to basically nothing, whereas things like the PPO and the point of service plans have gone up substantially. While this is happening, federal spending is, and I know this is surprising, going up. Medicaid expands in 1988 and 1990 to include pregnant women and children with below a certain income level. In 1996, Clinton gets welfare reform through, and one of the important things here is that Medicaid, which used to be tied to getting welfare benefits, is no longer coupled with it. So now, even though you're employed, if you're employed at a low-wage job, you're still eligible for Medicaid. So you're not completely cut out from getting your benefits. Why would you do this? Well, there's no point to an individual going out into the job market if they're going to lose all their benefits. 1997, CHIP, Children's Health Insurance, allows states to extend coverage to children up to 300% of the federal poverty level, which is about $25,000 for a family of four. So that's up to, a family of four, for example, would be up to $75,000 family income. And then lastly, in 2006, Bush I enacts Medicare Part D, where seniors get private prescription drug coverage, which is subsidized from the general tax revenues. So this is what happens. Medicaid expands, no great surprise. The blue line is the number of people that get it. The red line is how much is being spent. And what you can see here is that a program that started out with fairly modest intent of covering the indigent has now become a middle-class benefit. And you can also see that that expansion has taken place regardless of who's president, regardless of which party happens to be in power. Although there's, there are the occasional sort of little blip there where it stops growing. Essentially, what you have here is a hyperbolic curve. A little bit more on Medicare. Part D, the drug benefit doubles in 10 years. Part C, which is a HMO type form of Medicare that has a little bit of restriction of network in exchange for lower cost, triples. Parts A and B, which again are hospital and physician respectively, go up, but not as quickly. But the point is that as things go along, as we get more old people, more people that are eligible for Medicare, you can see what's happening is that the costs are going up and up and up. And keep in mind that Medicare is supposed to run out of money in 2026 or so. And you can see here, those numbers aren't going to get any better. And so this forms part of why bundled care is becoming such an issue. So just a quick reminder of who pays for Medicare, and the answer is you do. The vast majority of funding for Medicare comes out of general tax revenue and out of payroll taxes. So that little thing called FICA on your pay slip that takes as part of taking your income from, say $200 a week down to $97.13. Part of that is FICA. This is where it's going. You can see that the premiums that patients pay is in yellow there, and you can see that it accounts for a very small amount. So essentially what you have here is a lot of people getting a fair number of benefits with not a lot of skin in the game. So what about Obamacare? So there's a lot of fuss and bother about it. Here's a very basic idea of what Obamacare did. So first of all, it required virtually all U.S. citizens and legal residents to purchase insurance. It provides significant subsidies for low-income citizens and penalties. This is what's called the individual mandate for those who fail to purchase insurance. So there's been a dramatic expansion in Medicaid over the course of the last 5 years or so. The percentage of uninsured has dropped in this country, and the number of insured has dropped from 41 billion people to 27 million. The vast majority of those 14 million that got insurance, though, got it through Medicaid. So that's sort of something to keep in mind. So where are we now? Now at least theoretically, we know how we're going to pay for stuff, although the devils are going to be in the details, but we still don't know how to figure out what things actually cost. So that's the third and final section of this talk, which is how do we figure out what things cost? So this is what normal people do. They look for sales. They look at price tags, okay, and they buy what they can afford. And when you look at something like, for example, complicated like a mortgage, you say, I want to see an itemized bill of what I'm actually paying. Seems pretty straightforward, but it gets a little bit more difficult with medical goods and services. So how does a patient figure out how much something costs? The answer is lots of luck. This is a study that called a bunch of 20 hospitals, asked them how much parking cost, which is the right column, and got an answer from every hospital. They then asked, well, how much does an EKG cost? And they were able to get an answer from 3 hospitals. The first hospital said it cost $137. That was the bargain hospital. The second said it cost $600. The third said it cost $1,200. That's for an EKG, folks, okay? So if you called a hospital and said, I want an EKG, how much does it cost? They're going to tell you it costs $1,200 to get an EKG. What about if you want something a little bit more complicated or a bundled package? Let's say you wanted to find out how much your Aunt Edith is coming down from Canada. She wants her hip replaced here. How much is it going to cost? Well, you call up the hospitals and ask them. And what you find is that, and what this group did is they looked at 20 top-ranked hospitals in the country. They went to U.S. News and World Report or whatever, and then they picked 2 hospitals at random in each state, called them all and said, how much is a hip replacement going to cost? Well, what they found is that only about half could give you an actual price. Sometimes you had to make multiple phone calls to both the hospital and the surgeon, and eventually you could come up with an answer. But what you can see here is that the range of costs is tenfold. It goes anywhere from $12,000 all the way up to $125,000. That's for the same operation. That's for a total joint, okay? So the short answer is that asking what it costs doesn't work. And why is that? Well, the answer is the charge master. The charge master is a comprehensive list of items that are billable to a hospital patient or a health insurance company. And in practice, it's usually highly inflated, which is ranked at several times that of actual cost to the hospital. And this typically serves as the starting point for negotiations with patients and health insurance providers of what amount of money will actually be paid to the hospital. It's described as the central mechanism of the revenue cycle of a hospital. It is considered a trade secret, and the numbers in it bear absolutely no resemblance to anything that resembles reality. That being said, although it can be extremely difficult in many states to get a straight answer, some states do mandate that you say what it costs. So here's from California. This is UCSF, so University of California, San Francisco. This is a charge for x-rays. And take a look at what an x-ray of a femur costs. It costs $214. Take a look at what a thigh costs. Same x-ray. There's not much of a difference between a thigh and a femur. Costs $569. How about a knee? Well, you could get 3 views of a knee for $135, or you could get it for $574, which is 4 times as much. I would say that either cost is ridiculously inflated, but spending $600 for a knee x-ray seems a little bit odd to me. The federal government also requires that hospitals publish their numbers. So the feds have something called the Inpatient Utilization and Payment Public Use File, which provides hospital charges, specific charges for more than 3,000 hospitals in the Medicare system. There are 17 hospitals in the Seattle metropolitan area that do total joints under the DRG, disease-related group, 470, and the charges range anywhere from $31,000 to $103,000. Interesting, now that's fine, okay, we know that the charges are crazy. But what's interesting to me is that the payments, same DRG, same procedure, range anywhere from $11,000 to $18,000. And as try as I might, I could not come up with any explanation for why the prices or the fees paid ranged or differed by 40%. There was no correlation to zip code, teaching status, case complexity, volume, anything, phases of the moon. I looked for everything, couldn't find a single answer. So how do hospitals get paid? Well, Medicare pays hospitals a flat fee per hospital case based on a schedule of several hundred distinct disease-related groups. They assign a relative payment weight to each DRG, multiplied by various factors which depend on where the hospital is located, whether it's a teaching hospital, whether the case was complex, so on and so forth. And essentially, after a negotiation, the hospital gets paid something. So we still don't really have a straight answer on how hospitals calculate their costs. And here's how it's often done. So essentially the way the cost to charge works is as follows. In the last few years, we were reimbursed $10,000 for this service. We think we broke even. We charged $40,000 for it. Therefore, our cost to charge ratio for this year is 25%. Actually, we better ask for a little bit more. It's because we're building that new building, so it's going to be 30. So our cost to charge ratio is 30%. Now, because different insurers give different amounts of money for a different service, sometimes it's better to base costs on RVU, which is called a relative value unit. So Department A did this much work, expressed in RVUs, and we got this much money for Department A. So each RVU is worth a certain amount. We're going to repeat that for our departments A through Z. We're going to add it up, and that's going to be our RVU-based cost to charge. Now, try as I might, I can't come up with anything other than saying this is just a lot of, it costs $1,000 because we say it costs $1,000. And I have tried very hard to figure out how they actually come up with this, and I've really never come up with an answer. So what's kind of interesting here is that this is still considered a very reasonable approach, and you can actually publish things out of it. This is out of JAMA. And it's a little tough to read that, but it says, because actual spending is generally a fraction of the charge data were adjusted to reflect actual spending using a previously developed regression-based adjustment. That is the most elegant way of saying a fudge factor that I have ever seen in any article written anywhere. The problem, though, is the cost to charge varies by service, by what type of insurance you have, and by location. So, for example, here, all the way on the left, is trauma. So if you're private insurance, your cost-charge ratio is about 5. If you're public insurance, presumably Medicaid or Medicare, it's about 3, and if you're paying out of pocket, it's just under 3. You can also see that it differs depending on what kind of service you have. The other problem is that the cost-to-charge ratio has dropped over time, so using a fixed number is misleading. And here we can see that the previous study, which was looking at out-of-pocket costs, is probably wrong because they assumed that the cost-to-charge ratio stayed the same over time. So even though the charges have increased, the actual cost probably hasn't. So we fortunately can wrangle this all together, and so when a patient calls and asks what it's going to cost, with this very simple formula, you can easily determine the cost for a given patient. All you need are these numbers. Easy. Oh, guess it's not so simple. Well, let's look at pro fees just for an example. We do use something called the RVU system. This is much easier, as you can see. So when you're out in practice, this is how you're going to get paid. You'll have a work RVU plus a practice expense plus a GPCI plus malpractice. You'll multiply that by a conversion factor of 35.8887, and then you're going to get paid. So this is for pro fees, and this is actually published. This is easy. The formulas for hospitals are even worse and typically proprietary. I tried to get it for UW and gave up. And there are some problems here, aside from the fact that it's ridiculous that you can't figure out what anything costs. More importantly, this doesn't reward value. It doesn't reward quality. It has nothing to do with anything that we are looking to do. And the problem is that it leads to hospitals chasing services which provide the highest number of RVUs and cash per RVU. So there are a lot of perverse incentives here. So how much does it really cost? So there are various ways that you can do costing other than just saying, well, we charged this much, we got this much, therefore it costs this much. So we have something called activity-based costing, and essentially this is a business tool which is used to sort of say, okay, it costs this much at each stage of production. So, you know, to put on the chassis, it took us 4 guys, it took us this much material, and it took them this long, and they moved along. So the important thing about this is that it rewards the costs that traditional cost accounting doesn't do. It also records the costs of not doing stuff. The problem is that you can see this is for just one thing, and it becomes extremely difficult to do. But let's take a look at how this might work with a medical example. So cardiac surgery is a high-skill, high-visibility, resource-intense service line, which typically reimburses extremely well. So hospitals go after cardiac surgery very aggressively. And if you simply went with a, hey, we got paid a lot of money for this, it seems like a very reasonable option. But the problem is that you don't really know how much you're actually spending. So with activity-based costing, you look at how much each segment actually costs in terms of personnel and development or in equipment. For example, if you have a cardiac surgery program, you need a CCU, you need perfusionists, you need all sorts of special gadgets. And you might find out that cardiac surgery either breaks even or even loses money. It has some problems, though. First of all, it's hard to define how much expense is actually going towards useful activity. You might be paying people a lot of money to sit around waiting for things to happen, and as a result, you may be vastly overpaying for a given product or service, and it leads to misallocation of resources. Okay, so let's go back to that cardiac surgery example. Now, I know this never happens at UWMC, but let's say you have an OR suite where rooms sit empty for a long time, and the surgeons are always complaining that they can't get cases done. Okay, I mean, I know that would never happen here, but bear with me. So what does the hospital do? They increase block time. Okay, so they add nurses, they add staff, blah, blah, blah. It increases the hospital costs. And under an RVU system or under activity-based costing, that actually makes sense. Okay, you're adding supply to fit demand. But it may be that the reason for long waits isn't that the surgeons are slow or there's too much resources. It's that the PACU is backed up because they can't get the patients up to the floor fast enough because there aren't enough transporters. So time-derived activity-based costing is an attempt to fix this. And what you're doing is you're looking at every aspect of the service, and now you find out that the reason the OR is waiting so long is because there aren't enough people to take the patients out of the PACU and get them up to the floor. So what you find out is that porters cost you $20 an hour and are busy 90% of the time, so that rather than hiring another cardiac surgeon, rather than hiring more nurses, you get a few transport people. And now all of a sudden, your problem is resolved. So how's it done? You select a condition, you look at every step of the process, and you go through it. Here's the problem. It's hard to do. You have to dig down and look at every aspect of production, so it requires buy-in from everyone involved. And what you have to do is you literally have to track a patient all the way through the entire process of hospitalization and care in order to figure out how much everything is actually costing. I would say at this point, it's probably as good as you can get. There are some advantages to it because it's a bottom-up measurement. You can look at what it costs not just to do an activity, but what it costs to not do an activity. You can change things fairly easily. You can measure and move resources as needed. And what happens when you compare methods is that you find that if you do, for example, a total joint and you look at new accounting methods, you find that it costs about $13,000 to do a total joint versus traditional accounting, where it cost $24,000. Similarly, in cardiac surgery, what they found was that it was about 10% lower because they were more accurate at measuring what people were actually doing and how busy they actually were. So hopefully this is something that we're going to see over the course of the next few years as hospitals get more attuned to figuring out what things actually cost. There are weaknesses to any method of accounting. First of all, you have to account for indirect costs, which are things like administration, paying for new resources, capital costs, things like that. The other thing is that somebody still has to pay these costs. And the problem with something like time-derived activity-based costing is it's a double-edged sword. You can look at it and go, hey, look, we're actually really efficient, and we're actually only spending $12,000 to do a total joint as opposed to $25,000 a joint. But the problem is the payer, the federal government, is looking at this going, hey, wait a second, you told us it was costing you $25,000. Now you're saying it's only $12,000. Well, guess what? We're paying you $12,000. We're no longer paying you the $25,000. It can't account for the black swan, where you have a patient that, for whatever reason, instead of costing $12,000, costs $300,000. And there's always some level of subjective involvement. So here are my final reflections on healthcare system. Current system's nuts. Number one. Number two, money drives behavior. It's very nice to say that we're all Albert Schweitzer and Florence Nightingale, but we are not. Money does drive behavior. We should admit it and move on. I would say bundled care for things like total joints and specific discrete episodes makes a lot of sense. It's here to stay. And basically, it's how normal people pay for normal stuff. And then finally, both cost and effectiveness and quality are in the eye of the beholder. Thanks. Does anybody have questions?
So we have one question that was submitted electronically. What domains of the promise are required or suggested in the CJR program? They ask for the Promise 10, which is a 10-question assessment of general health.
Yeah, it's fairly straightforward, and you can actually incorporate this into an electronic medical record without a whole lot of trouble. Other questions?
That was awesome. Thanks, you guys. Do you see any avenue in the future to open up the black box to find out how much stuff costs? Like, is there like a way out to get that information in your mind?
Boy, that's a good question. The question is, how do you open the black box and find out how much things cost? It is interesting because Randy Marcus at the Cleveland Clinic just published a study that looked at the growth of wages for administrators versus the growth of wages for nurses and doctors in this country, and it's fairly surprising how much the difference is. The other thing that's interesting is that for every physician, in the healthcare system, there are 10 non-clinical employees. So there are a huge number of people that are doing stuff that is probably worth it, but it's hard to say. And one of the ironclad rules of bureaucracies is that they expand. So, you know, I think that it would be nice to figure out a way to figure out what these people are doing all the time. I mean, they're good people, they're working hard, and they're doing stuff. You know, the question is how much of that activity is actually useful, and that's a very hard question to answer. I suspect it's going to come down to the federal government telling people or telling hospitals that they have to open up the box, because I don't think it's going to happen voluntarily. You know, I think what's going to happen is CMS is just going to say, hey, listen, guys, you have to give us a line item list of what you're actually spending money on, because I can't imagine that a hospital is going to do it any other way.
Well, Hank, that was phenomenal. The history that you distilled and shared clearly was just profound, and I really appreciate you taking the time to do that. So recently, Children's made it available to us to get at cost. Charge was different. Different people received different charges, but what it was costing. And so there was a patient who had a delayed diagnosis, a child with a septic hip. And she'd been seen at numerous other facilities, and nobody had made the diagnosis, and she finally got to us with a fever of 107, septic, and almost died. And so she ended up with an infected thrombus, and then she had pneumonia, and she was in intensive care. She had multiple washouts. Long story short, it was this, what did it cost for us to miss her diagnosis? So we did a study, and we looked at all of the septic joints and the diagnosis time. If you are more than 4 days from the time of onset of symptoms, the cost goes from $100,000 of treatment to $250,000. So I guess the impetus was, I can't control the federal government, but if I can show where the value of the care of people who are really good physicians who know what to do and do the right thing, that cost, that savings, to me, that's where we show our value, because it's something that we can study and prove that highly qualified individuals who really are attentive to these details, who don't not get the labs when they should and know what the right thing to do, are extremely valuable and perhaps should be more highly reimbursed. So that was just a thought on a frustration about a kid's care, but this was really, thank you. And there is data available at Children's if people want to look at it.
So fair enough. I mean, I guess what I would say there is, if I was a hospital person and I was getting paid a fixed amount by the state, in this case, because I'm assuming it's probably Medicaid, I would do everything I could to keep the costs down. If I was a hospital administrator and I was still getting paid usual and customary, as in, hey, we billed $500,000 and we're going to get paid 50% of whatever we bill. Well, I mean, it's a bit of a perverse incentive. It's no longer an incentive to give good care. It's an incentive to give expensive care. And good care is not always the same as expensive care. In this case, obviously, the two are diametrically opposed. So, part of the reason that things are so screwy is because there are an awful lot of perverse incentives going through the system. And when you get paid more for doing more, that is a perverse incentive. That being said, if you're getting paid more to do less, that's also a perverse incentive. So it's not an easy, there are no easy fixes here. That's the short answer, okay?
Yeah, thank you, Boris. That was a great introduction, and I agree. You learned a new language somehow in the midst of being a busy resident. So a couple of comments, even going back to the beginning of the talk, the BPCI and CJR initiatives. It's really hard to get a handle on this because one problem with those is you both presented data. I think Boris presented data saying that those programs were effective at improving quality and value. But they're looking at 90 days. And I don't know if Paul remembers, but when we were looking at our care maps and trying to, get into the bundled game and be successful at it, which we were, we noticed that a few of the groups around King County were using some what we would say were, outmoded prostheses, without going into any details that none of us would have wanted to implant in any of our patients or get ourselves. And so it was from the 90-day, episode, it became sort of an incentive to save costs in that period, even if it compromised the end result, years down the road. And for total joints, 90 days is important, but I think you could argue that what happens over the next 5, 10, 15, 20 years is probably actually more important. The other thing I was going to say is that there's a famous graph that is out there, and I think it's based on data produced by the General Accounting Office that looked at the growth in the number of administrators working in our healthcare system versus the number of physicians. And the interesting thing about that graph is that I've seen it projected with that slide right there. And that red line corresponds almost exactly to the increase in the, administrative, load in hospitals. And the bottom line, the blue line, patient enrollment corresponds to the slight increase in the number of physicians over the last 20 years. And so again, I agree with Paul. These jobs are probably important, but we can't ignore that that's a significant chunk of the increase in healthcare costs. And we sat down and we looked at the cost of absolutely every aspect of our total hip and total knee cases. But even when you're done with all of that and you break that down into, so many different costs and charges, you're still left with the big black box of indirect costs, and nobody can really get a handle on that. So I think this is going to remain really challenging, even if you look at things like time-based, cost accounting. It is really difficult. So we need to continue the good fight.
Great. Vince?
Thanks, both of you. I've never heard anything that good on this topic. And it's so great that it's going to be available online. And I know I'm going to go back and look at it more slowly. I thought I knew a lot of this, and I learned so much this morning, so thanks. It's hard. What does something cost? It's what you charge. And so when we buy our TVs, we say that one costs that much, and that one costs that much, or that one costs that much at Costco, and that one, the same one costs something else someplace else. I think healthcare is the only thing you can't ask really how much it costs. Your lawyer costs $400 an hour, and that's whether it's on the phone or in person. You can get a handle on everything else you buy, and you can decide if you want to buy it or not healthcare. I've tried for my whole career to find out how much x-rays of a foot cost, and they won't tell me. They will not tell me. I mean, it's like, hey, I've been here longer than you. You got to tell me. They won't tell you. It's absurd.
Do they know?
They know, and they say, it depends. And I said, what do you mean it depends? It's the same x-ray whether you do it on somebody poor or somebody rich, but they charge differently. So a couple issues. Another issue is, what do things cost? Well, how come orthopedic surgeons make between 6 and 10 times as much money as primary care physicians? We're not smarter. We're not better.
Let's
No, but that's going to come up. Someone is going to bring that up. When they're saying you have to control your charges, and if we're tied up at the hospital, and the hospital says, well, you're all docs, we're a hospital. In other countries, orthopedic surgeons make what primary care docs make. Spine surgeons make what Ponseti clubfoot treaters make. We're going to have to figure that one out too. And for your future, you're going to have to say, why am I, as an orthopedic surgeon, better than some other physician? We train the same.
So, it's a very fair point. So to the point of how much does a normal, very straightforward, easy thing like an x-ray cost, and why can't you get that answer? Let's go back to that EKG example, okay? It went anywhere from $137 to $1,200 for an EKG. Well, an EKG technician makes $50,000 a year, let's say, all right? So that means they're being paid $25 an hour. let's say they can do 5 EKGs an hour. So the labor costs are $5. An EKG machine costs, and let's get the top of the line, probably $5,000, okay, which you can depreciate because it's a capital expense. So realistically, that EKG, and I'm going to throw the cardiologist a bone here for interpretation, should cost $10. Okay, cost $5 for the technician, cost a few bucks to process it, blah blah blah. An EKG should cost $10. There is no earthly reason why a patient should be charged $1,200 for it. There's no earthly reason why somebody should be charged $20 for it, but there's certainly no reason why you should charge somebody $1,200 for it. As far as why do specialists get paid so much more than primary care people? I mean, part of that is length of training. Okay, part of it is complexity. Part of it is the idea that there are more people that can do what they do versus what we can do. But a huge part of that imbalance comes from the RVU system. All right, the relative value unit, which is basically a bunch of learned people in Washington, D.C. sit down every year and decide total hip is 35 RVUs, talking to a patient for 40 minutes about their diabetes, their depression, the fact that their dog just died and their wife just left them is 3 RVUs, and therefore, that 40 minutes, you're going to get paid, whatever, $60 for it, okay? The guy down, in the next building, the total joint surgeon, is going to do that total joint in 40 minutes. He's going to get paid $1,500. I can't explain it, okay? I don't know why that is. Short answer.
Just a follow-up comment on that. So we haven't decided the RVU, pay scale, obviously, but all of our groups lobby to have those adjusted in the proper direction for our profession. But it even goes beyond that. I would argue that looking at things like quality or disability adjusted life years even might be a rational way to pay people for taking care of patients because there are benefits to society at large, benefits, in addition to benefits to the patient. I was just going to ask, do you know within academics now, according to the double AMC guidelines, what the highest paid physician is in academia now? Does anybody know?
He's probably a dean somewhere. I don't know. But
No. Well, as a group. Yeah, they're Mohs surgeons, which, now exceed neurosurgeons, orthopedic surgeons. And again, so some of that is based on volume, but some of it is also based on, some group deciding, RUC or something deciding what the value of an individual Mohs surgery is. And so, again, it's super complicated, and I don't know how we're going to get a handle on that. The only thing I think that's given is that the cost of healthcare is going to continue to expand faster than the pot of money to pay for it.
until it can't.
Yeah.
So, good. Any other questions before calling today? All right. Thanks, everybody.
Thank you all.